In this session, we're going to review the basic principles underlying pouching and peristomal skincare. And we're also going to talk about common types of peristomal skin breakdown, causative factors, clinical presentation, and guidelines for management. Now, in talking about peristomal skincare, a lot of it goes back to matching the pouch to the patient's abdominal contours, selecting appropriate products for skin protection. In this class, I'm going to go over the basics, but when you come on site for Bridge Week, we're going to spend a good bit of time going over this in detail, looking at the different characteristics of pouching systems, the implications matching pouches to patients. You'll also practice doing patterns and making sure you get patterns done correctly, and you'll actually wear a pouch. So we're just going to go over the basics in this session right here. So first of all, in teaching patients, you have to remember that even for patients with a temporary ostomy, they're going to expose the peristomal skin to repetitive application and removal of a pouching system. And for the patient with a permanent diversion, of course, it's even more long-term. So there's some basic things we want to emphasize when we teach patients how to do their pouch change procedure. And the first thing is we want to emphasize the importance of very gentle technique for pouch removal. We talk about the push-pull technique, which you use every day when you take off adhesive products, when you push down on the skin as you're pulling up on the adhesive product. You'll watch your patients, and sometimes they want to do the Band-Aid approach and snatch it off. So again, important for us to tell them that works for a Band-Aid because you're not going to be wearing that Band-Aid for weeks, months, years. But you can't do that to your peristomal skin. You've got to be very gentle in your approach to pouch removal. In terms of cleansing, it depends on whether they're cleaning their stoma while sitting at the bedside or sitting in the bathroom, or if they're in the shower. So if they take off their pouch and get into the shower, which is one option that they have, then of course they're going to use their shower gel or a mild cleansing agent. And the main thing is to be sure that they rinse thoroughly to eliminate any soap residue and to eliminate any emollients, because you want to end up with a clean, dry surface to which the pouch will adhere effectively. If they're sitting in the bathroom and cleansing their peristomal skin, we typically encourage them to just use warm water, not to use soap at all, because it's so hard to effectively rinse away all the residue of the soap. And warm water is really all they need. So if they're sitting at the bedside, just warm water. If they're in the shower, of course, they're going to use their usual cleansing product, but rinse thoroughly. If they're away from home, if they're out camping, or if they are putting together their emergency kit, they have a couple of choices. They can take some paper towels, moisten the paper towels, put them in a Ziploc bag so that that goes with them wherever they go. Or they can select some skin cleansing wipes that do not contain any emollients. For example, Tux makes a disposable cleansing wipe with no emollients. And then the third thing is hair removal. Some of your patients will be lucky. They'll have very little abdominal hair and it won't really be an issue for them. For other patients, it's a major issue. Here's what we have to worry about. When you put the pouch, let me just get a pouch. When you put this pouch onto the peristomal skin, any hair in that area tends to grow into the barrier and embed into the barrier. And then when you take the pouch off, you're snatching the hair out by the follicle. And that causes trauma to the hair follicle. Once you get trauma to the hair follicle, then you can get bacterial invasion and you can get a folliculitis. So we're always trying to prevent folliculitis and prevent damage and, of course, prevent pain. So one of the things we tell our patients is if you have hair in the peristomal area, you probably want to remove the hair on a routine basis, typically about weekly. Some people do this every time they change their pouch. You can clip with scissors. You have to be very careful not to nick the skin. And one negative thing about clipping is you tend to leave a short stubble behind, which is more likely to ingrow into the barrier. Another approach, one that we tend to favor, is to use an electric razor, which is very safe, but does take the hair off down to skin level so that you have less potential for ingrowth. They can use a safety razor and shaving cream, or a safety razor and a dry powder. But they have to be very careful because we do not want them to nick the skin. And of course, we have to teach them to begin at the stoma and shave out. So most of the time, we just encourage them to use an electric razor if they're going to shave the peristomal area. Now, if you have a patient who has an extremely hairy abdomen, they may very well want to consider laser hair removal so that they're not dealing with this over and over. Now let's talk about protecting the peristomal skin. We've talked about routine care, gentle removal, appropriate cleansing, and management of peristomal hair. The other thing we have to think about is protecting the peristomal skin from the drainage. And in looking at drainage, specific factors to consider are whether or not that stoma is draining fluid that contains enzymes, and specifically proteolytic enzymes, or enzymes that are designed to break down protein like skin. So we know that small bowel fluid is very high in proteolytic enzymes and very damaging to the peristomal skin. Gastric output, very high in proteolytic enzymes, very damaging to the skin. The second thing we have to think about is pH. The skin, as you know, is very slightly acidic, but very slightly acidic. If you have drainage that's highly acidic or drainage that's highly alkaline, that's going to be more irritating to the skin because there's a greater deviation between the pH of the drainage and the pH of the skin. Two things to think about specifically: gastric output. So if you have a leaking G-tube, you know how damaging that output is to the skin. High levels of proteolytic enzymes, highly acidic. Pancreatic fluid, very high levels of proteolytic enzymes, highly alkaline. So the greater the difference between skin pH and the pH of the drainage, the greater the likelihood for damage. Also, of course, volume and consistency. So if you have a high output stoma, you're much more likely to sustain skin damage than if you have a stoma that has relatively low volume output. Very liquid output is much more likely to tunnel under the barrier and to cause skin damage or to wash the barrier away, whereas more solid drainage is much less likely to do so. So always think about, does this drainage contain proteolytic enzymes? Is the pH of this drainage close to that of the skin or very different? Do I have high volume or low volume? And do I have liquid or more solid? I'm going to go back. So putting that together for our ostomy patients, when we think about patients with ileostomies, patients with colostomies, patients with urinary diversions, our patients with ileostomies are going to be the highest risk for skin breakdown because small bowel fluid is high volume, typically liquid or very thin mush, and has high levels of proteolytic enzymes. In contrast, for the patient with a colostomy, a large bowel stoma, either minimal residual enzymes or no enzymes at all, relatively low volume, and soft deformed consistency. In looking at urine, urine has no enzymes. The pH is usually very close to that of the skin. So urine causes damage to the skin only if it is allowed to pool on the skin, only if you get prolonged contact. So it means in a patient with a urinary diversion, our major focus is establishing an effective pouch seal so that the urine flows into the pouch and is not sitting on the skin. Now, other things that we have to think about in protecting the peristomal skin, We have to worry about mechanical trauma. We've already talked about the potential damage that could occur with snatching the pouch off. We also have to talk to patients about gentle skin care, not picking at the skin, not picking paste off, not scrubbing the peristomal skin, because those approaches to peristomal skin care could also cause superficial skin loss, skin breakdown. We have to realize that some of the products we use, if used incorrectly, can cause a reaction, a chemical reaction. And the two products that are most likely to do this are your solvents and your adhesive products. Solvents come with chemicals that break the bond between the adhesive and the skin. So whenever we use a solvent, we need to gently clean the skin to remove the solvent so that we do not get a chemical reaction. When we talk about adhesive products, a lot of our adhesive products are mixed with a solvent to keep them in liquid form until they're applied. And it's very important to allow those solvents to evaporate, to allow that adhesive product to dry before we apply the pouch. If we apply the pouch before the adhesive product has dried and before the solvent has evaporated, we're trapping that chemical next to the skin, and we're much more likely to cause a reaction. And finally, any product we use can cause an allergic reaction. All of the products are labeled hypoallergenic, meaning that the companies have worked hard to minimize the risk of an allergic reaction, but there's no such thing as a product to which no one will react. So we have to watch our patients and be aware that yes, they could develop an allergy to one of the protective products we're using. So going through here, we've already talked about the importance of using gentle technique for pouch removal, gentle technique for skin care to prevent mechanical trauma. We are next going to talk about appropriate use of protective products. If we use protective products appropriately, that will help us to protect the patient against damage to the peristomal skin caused by the drainage itself and damage caused by inappropriate use of products. So we're going to talk about how to use skin sealants, when to use them, how to use them correctly, when to use your barrier products like rings and paste and strips, how to use those correctly. And then we're going to come back to the importance of establishing a secure pouching system, how we match the pouch to the patient, and how we minimize episodes of leakage. So let's move into appropriate use of protective products. And when you look at the products we use on the skin to protect the skin, they fall into two major categories. And the first major category is what we call skin sealants. And these products are called skin sealants because they leave a clear protective film on the skin that essentially seals the skin and puts a layer between the skin and the pouch, between the skin and the adhesive, between the skin and the moisture and the drainage. So it essentially seals the skin. Now, sealants have two primary effects. And so when you think, when should I use these products and how do they help? Go back to what they do, and we'll talk about what they don't do. They have two major benefits. They're listed on the slide, they're listed on your handouts. First of all, they help to waterproof the skin. Just like I said, they put a clear plastic film on the skin that creates a moisture barrier so that the moisture in the output doesn't come in direct contact with the skin. For patients with urinary diversions, this is usually the only skin protection you need because all you need is protection against moisture. Urine has no enzymes, so you're simply protecting against the liquid aspect of the output. So first of all, they waterproof the skin and protect against moisture. In addition, when you put that layer on the skin, you actually create like an extra protective layer of the skin so that when you take tape off, when you take the pouch off, instead of pulling on the top layer of the skin, you're peeling off this plastic film. So use of these skin sealant products also helps to protect against what we call tape stripping or tape damage. Helps to ensure that when you take the tape off, you won't take off skin as well. Now, I will go ahead and mention the fact that some companies recommend that you not use skin sealants under their pouches. And when they make that recommendation, I want to explain why. And we'll come back to this when you're on site. So the barrier products that you will find on the back of your pouches are designed to literally melt into the skin. They are adhesive, but they're also heat activated, and with heat, the pectin and the gelatin and the other synthetic substances in this barrier become partially fluid and literally melt into the grooves in your skin. So they're really designed to adhere to clean, dry skin. If I put a plastic film on the skin, it can interfere to some extent with the barrier's ability to melt into the grooves of the skin. However, as you will see when I go to pull this off, it still sticks pretty darn well. So you have to use your own clinical judgment. I just wanted to point out that that's why companies will sometimes tell you that, and I understand where they're coming from. But as a clinician, I know that in many situations I actually get a better seal when I put down the skin sealant first and then put the pouch on top. Some of you, if you look at what's being done in your clinical setting, you'll look at your standard procedure for pouch application, and it will call for application of a skin sealant like Skin Prep or Sure Prep or All Care or Cavalon, allowing that to dry and then applying the pouch. So I don't want you to think that that's necessarily wrong. I want you to know that there are reasons you might want to try the pouch without the sealant, and I want you to realize that some patients actually get a better seal with the sealant. So don't make it either or, don't make it black and white. Okay, so skin sealants as a category, very effective at waterproofing, very effective at providing protection against tape trauma, tape damage when you remove the tape, when you remove the pouch. We also use our sealants for a procedure called crusting, and crusting is a procedure we use to treat damaged peristomal skin. I'm actually going to come back to that, but I'll describe briefly what that is. It involves sprinkling a layer of pectin-based powder onto any damaged skin and then blotting over the powder with one of these plasticizing wipes or spraying with a plasticizing spray so that you end up with a protective layer next to the damaged skin and then a top plastic layer that allows you to pouch. We'll come back to that. Now let's talk about the major types of sealants that are on the market. Most of them come in wipes or swabs. They also come in a spray form. You can divide them all into a couple of categories. Most of them are alcohol-based, which means that the solvent that is used to keep that plastic film in liquid form is alcohol. If you're using an alcohol-based sealant, once you wipe it onto the skin or spray it onto the skin, the alcohol evaporates rapidly and leaves the plastic film behind. If the skin is intact, there's no problem with using an alcohol-based sealant so long as you're using it on older infants, children, and adults. We do not use alcohol-based sealants on neonates or on premature infants because we're concerned about alcohol absorption through the skin. But for any other patient with intact skin, an alcohol-based sealant is fine. There are a couple of alcohol-free sealants on the market. Probably the most well-known is Cavalon by 3M. They were the first one to come out with an alcohol-free sealant. However, there are now others on the market. There is a Skin Prep No Sting that is also alcohol-free. When do you need an alcohol-free sealant? And of course, you're already thinking of the answer whenever you have damaged skin. So if you have skin loss, open areas, application of an alcohol-based product would be painful. So you would reach for an alcohol-free sealant in those situations. So intact skin, you typically use your alcohol-based sealants because they're less costly. But for damaged skin, you're going to go for an alcohol-free sealant to avoid pain and trauma to the patient. Then the last classification is washable versus resistant. Most of the sealants that are on the market are washable, meaning that if you put them on your hand and then you go wash your hands with soap and water, they wash off. And that's not a problem because think of how we use them. We use them under tape, under dressings, under pouches. We frequently, inadvertently, get some of that plasticizing film outside the area where the pouch is adhering, outside our tape border. But it's not a problem because when we bathe, it just washes off. And the skin is still protected because the area of the skin covered by the sealant that is also under the pouch or under the tape isn't exposed to the soap and water. So standard issue sealants are washable with soap and water, which is fine. But there are some sealants that are very resistant to washing, and those are the ones that we use if we have an area of skin where we're trying to provide protection and we know that skin will be exposed to soap and water. The perfect example is if you have perianal skin breakdown, and maybe you're sprinkling on your ostomy powder and you're spraying or you're blotting with your plasticizing film, and you know that patient's going to have additional incontinent episodes and you know somebody's going to be cleaning them up. In that case, you would want to have a sealant that was resistant to soap and water, resistant to cleansers, and that would not break down. One of the most resistant sealants is your Cavalon. So if you're using a sealant for perianal or perineal skin protection in a patient who already has some degree of skin loss, you are probably going to reach for Cavalon by 3M because it's alcohol-free and it's resistant. But if you're reaching for a sealant to provide protection under tape, under a dressing, under a pouch, then any of your sealants would be acceptable. So you could use alcohol-based and you could use one that's washable, and those would be less expensive. So you just want to know the features so that you can use products appropriately. The second big category of products is your barrier products. And barrier products actually put a solid layer of product in between the skin and the drainage. Barrier products come in solid barrier wafers and rings. They come in a squeezable paste. They come in paste strips. So let's look at each of those. But first I want to go back to the major benefits provided by your barrier products. Sealants, waterproof, and protect against tape damage. Barrier products actually protect the skin from the enzymatic drainage itself because they put that solid layer of protection between the skin and the drainage. So if you have a patient with an ileostomy, it's not going to be enough to use one of your skin sealants. You also need a barrier product, something that goes on top of the skin and that separates the skin effectively from that enzymatic high volume drainage. The other thing that barrier products do, because they're very soft and moldable, and I'm just going to show you some different things right now. So your paste and your barrier rings and your paste strips, because they're very soft and moldable, you can use them to fill little defects in the peristomal surface to give a flatter pouching surface. Obviously, if you can get a flatter pouching surface, you're going to get a better seal. So we use barrier products to protect against drainage, and we also use barrier products to help maintain an effective seal. Sometimes we need both. Sometimes we need only one. But our barrier products are always there to do those two things, to protect against drainage and to provide a better seal. So let's talk first about barrier rings. Most of your barrier rings will be incorporated into your pouches. So most of your one-piece pouches have a barrier ring and then a tape border. So you see the barrier ring is already incorporated. Your two-piece pouches, in this particular case, there's only barrier. There is no tape border. So the two-piece system comes with a barrier ring, okay? So in both of those situations, the pouch comes with the barrier. When you apply this pouch, you have applied a layer of protection against the drainage. And you also have an interface layer. The layer that's going against the skin is very soft and moldable, so it's able to contour to creases to give you a better seal. You can also get accessory rings. So if you had a very high volume output ileostomy and you were having trouble maintaining a pouch seal because the drainage kept tunneling underneath the barrier, you might elect to take an additional barrier ring and to fit this barrier ring around the stoma, stretch it into place around the stoma so that you're adding protective material. So sometimes we will add a barrier ring if we have very high volume output and we need more protection. Sometimes we'll add a barrier ring if we need to fill defects. So maybe I have kind of an oval defect around the stoma and I want something that will fill that defect and will be moldable, then I could reach for a barrier ring to do that. They come in round, they come in oval. One of the nice things about barrier rings, they're sticky on both sides. So if I have a little defect on one side of the stoma, I can pinch it together, push it into that defect, fill that defect, and stretch the remaining barrier ring around my stoma. So you can see that barriers do those two things. They protect against drainage, but they can also be used to create a flat pouching surface and to give you a better seal. So we talked about barrier rings. I want to talk about paste. Paste is a very powerful tool when you're pouching because you look at paste as caulk. If you were redoing your bathroom, you would definitely need caulk to fill between the tiles, to fill the gap between the sink and the wall, to fill the gap between the toilet and the floor. You always need caulk. Paste, when we're talking about stoma paste is not adhesive. It is not glue. It is not used to stick the pouch to the skin. It is used to fill small little defects. It is used to caulk and to protect that little bit of skin between the stoma and the pouch, because it's very hard for patients to cut the pouch exactly right. Sometimes they need to cut the pouch a little bit wide. They need paste. In some settings, they use paste very little and they use the barrier rings a lot. But when patients go home, you want to remember paste is much less expensive. It's an easier thing to teach patients once they go home. So you think of paste as kind of standard care and your barrier rings as something to be used in situations where you have a higher risk patient, where you have a more difficult situation. Also, we have paste strips. Now let me explain why we need paste strips. Almost all of the commercial paste on the market is alcohol-based. What keeps the paste in this tube in squeezable format so that the patient can literally squeeze it out around the cut opening in their pouch, and then when they put it on, they have a ring of protection around the stoma. But what keeps that paste in squeezable format is alcohol. Once I put the paste on the skin or on the back of the pouch, the alcohol evaporates. and this becomes solid. But that also means that if the patient has severe skin breakdown, you don't want to use commercial paste because it's going to sting. So what we have in those situations is we have commercial paste strips. They're pre-formed paste. And what I can do with these paste strips is I can pinch off however much I need. If I need it to fill a little gully, I can do that. If I need to create like a little ring around my stoma, because the patient has raw skin, I can create a little ring around my stoma, so I can do what I need to do with these paste strips. Now, are they more expensive than the paste in the tube? Yes. So do I use paste strips as standard approach? No. But I want to know about paste strips because if I have a patient with significant peristomal skin breakdown, I'm going to need my paste strips because I do not want to use my alcohol-based squeezable paste. So you think of tube paste and paste strips is basically doing the same thing, but this one's alcohol-based, so should be used on intact skin. This is kind of routine use. This is alcohol-free, more expensive, so you reserve this for situations when you can't use your tube paste. So these are your primary products in providing a secure pouch seal and protecting against drainage and against moisture. You think of your skin sealants as primary protection against moisture and against tape damage. This is usually all we use and all we need for a urinary stoma. We don't use paste for a urinary stoma because urine melts paste. So you'll hear that over and over again. So for a urinary stoma, we typically use pouch plus sealant. Sealant protects against moisture. Sealant protects against tape stripping. That's usually all we need. But for an ileostomy, we're going to typically use paste right around the stoma plus our pouch. If we have raw skin, we're going to reach for our paste strip to put a barrier around the stoma. If we have very, very high volume output and we need an additional layer of protection, we'll reach for our barrier ring. So tube paste, strip paste, barrier rings, they're used somewhat interchangeably depending on what we need. Standard caulking, standard protection, intact skin, tube paste. Standard protection, standard caulking, damaged skin, we typically use strip paste. Very high volume output where we need additional layer of protection, we're much more likely to use our barrier rings. Also, if we have significant defects and we need to be able to pinch and fill, we're more likely to use our barrier rings. So again, we'll talk more about that when you come on site. Now in your handout, you also see a discussion of the different types of barriers. I don't want you to get lost in that at all right now. I will tell you that the vast majority of the barrier products on the market, most of the barriers attached to your pouches, essentially all of your barrier rings, actually all of your barrier rings, your paste strips, and your tube paste are made out of pectin, gelatin, carboxymethylcellulose, and other synthetic products that are designed to be resistant to breakdown by small bowel and large bowel output and enzymes, that are designed to be conformable and to promote a good pouch seal. So whether you're using a Convatec product, a Hollister product, a Coloplast product, almost all of the protective products you use are going to be pectin, gelatin, carboxymethylcellulose based. And what those products do a very good job of doing, either in combination or individually, is conforming to the peristomal skin and resisting breakdown. There's a category of products that are known as extended wear products, and those are products where the formula has been tweaked to make them more resistant to breakdown. And those are the products we typically use for our high volume ileostomy patients and our urinary diversion patients. When you come on site, we'll talk a little bit more about the barriers that are available, the pouching systems that are available that do not contain pectin, gelatin, those products. The reason we talk about those is because you will occasionally have a patient who develops a pectin allergy or an allergy to one of those synthetic products. If they develop an allergy to pectin or one of the other synthetic products, the issue is those are the same products that are used in everyone's barrier products. So it's not like I can shift from Hollister to Convatec because I'm still using the same products. It might be a slightly different recipe, but the core ingredients are the same. There are a few products on the market that use different barriers, so I'm going to mention two of them and show them to you now. We'll talk more about them when you're on site. One of them is Skin Shield by Marlin. And I know on video it's going to look very much the same, but when you come on site, you'll see that you can literally feel the difference and see the difference. Most importantly, you'll have the information that Skin Shield is non-pectin based, so you know if you order that from the catalog, you'll be getting a product with no pectin. It's actually made out of an extruded rubber that has no latex, so it's non-latex, non-pectin. If you have a patient who develops a pectin allergy, you want to be able to go to your materials and look this information up so you know where you can get a product that is not pectin based. The other major company is New Hope. And New Hope makes a product that has no plastic barrier. It's an adhesive foam. The adhesive foam acts like a barrier in that it's very sticky, it contours very effectively, and it's very resistant to breakdown. But it has no pectin, no gelatin, no carboxymethylcellulose. So I just want you to know at this point that even though well over 90% of the products on the market are pectin, pectin gelatin, pectin CMC, or all three, there are companies that make non-pectin, non-gelatin products that are available should you have a patient who develops an allergy. Pectin, gelatin, carboxymethylcellulose allergies are rare. But as the ostomy specialist, we need to know that there are products out there that we can use should we have a patient who develops an allergy. So right now I'm just mentioning that to you. We will go over that with you again when you come on site. At this point, what we want you to be focusing on is why do we use barriers? What do they do? And when you look at them, when you look at the products that you're using in your facility, you're going to recognize they're soft, they're adhesive, they're moldable. And many of the products like paste and paste strips and rings can be used to fill defects. So they help you maintain an effective pouch seal, and they're solid, so they give you extra protection against drainage. Now, the last product I wanted to mention is powder. No matter where you work, I'm pretty sure you have access to ostomy powder. Ostomy powder is pectin based. When you sprinkle this onto damaged skin, it forms a very thin protective gummy layer. I liken it to an ultra thin hydrocolloid, so kind of like a Duoderm, extra, extra, extra thin. But the point is, when this mixes with moisture, it does form a gummy layer, and that gummy layer is protective for that underlying skin breakdown. However, the pouch won't stick to the powder. So that's why we use the technique called crusting. So first we put down the powder, it interacts with the damaged skin to form a gummy protective layer. Then we take our wipe or our swab or our spray and we blot over it We don't wipe, we blot. And even though it initially looks as if we're taking all the powder up, as you'll see when you come on site, or you can try this yourself and you'll see it, once that sealant layer dries, you have a plastic film on top, but you can still see the powder underneath. So this is what we call crusting. And crusting is a universal first aid technique for damaged peristomal skin. Sprinkle on the pectin powder, dust off the excess, and then either spray or blot with your skin sealant so you have a plastic cover film. Okay, so now let's talk about some general characteristics or general principles related to pouching. We've talked about how we protect the peristomal skin. We teach patients gentle skincare. We teach them not to use soap unless they can get all of the soap off. We teach them to use sealants appropriately. We select the barrier products that they need based on their abdominal contours and their need for a filler, based on the type of output they have and their need for additional barrier products. Now we're going to focus on what are the things we can do to make sure that they maintain an effective pouch seal, that they minimize the risk for leakage and for skin breakdown. So in looking at pouching, our goal for all of our patients is a predictable pouch seal, predictable wear time. I want my patient to know that if they change their pouch on Monday and Thursday, that they can go about their activities of daily living without worrying about their pouch is going to stay on, and that it would be highly, highly unlikely that they would have an episode of leakage. If I never know when my pouch is going to come off, it's very hard for me to re-engage in activities of daily living because I'm worried all the time. So I want them, you want your patients to have a predictable pouch seal, predictable wear time. Typically we teach them when they go home from the hospital. In the hospital, we were changing your pouch every 2 days. So we know your pouch will stay on for 2 days. This is Friday. We just put a pouch on. So based on what happened in the hospital, you would change your pouch on Sunday. Now, on Sunday, if you check your pouch seal and it seems to be very intact, there's no evidence of leakage, there's no itching, there's no burning, the barrier on your pouch doesn't feel abnormally soft, then you can extend your wear time by 1 day and you can change your pouch on Monday instead. When you take your pouch off Monday, look at it. If the pouch is very much intact, the barrier's not washing away, your skin looks great, then you can try going 4 days. So you could say, okay, I put it on Monday, so I'm gonna check it. I'm gonna check it on Wednesday, but if everything looks good, now I'm gonna wait till Thursday. So that's how you gradually stretch out your wear time until you determine what's the best wear time for you. What's the best balance between a secure pouch seal and relative ease of removal? So you want to remove the pouch when it's still stuck down, but when it's starting to soften and so that separation from the skin is easier. That's usually at about 3 to 4 days. So what do you see here? Across the United States, studies have shown that most patients change their pouch every 3 to 7 days. Patients have to figure out what works best for them. Now, obviously, we know that the stoma starts out swollen. It's going to shrink down over the first 6 weeks post-op. So we want the patient to resize their stoma at each pouch change, or at least every week, until their stoma stops shrinking. And how do they know it stops shrinking? It stays the same for 2 to 3 measurement periods. Then they can stop measuring. Now, in teaching patients how to size the opening in their pouch and teaching your staff how to size the opening in the pouch, the most important considerations are whether or not the stoma protrudes or is skin level. If the stoma protrudes, if you have a stoma that looks like this, which is everyone's dream stoma, this is what you would like the stoma to look like. If it looks like that, then almost any pouch is going to adhere effectively, and your goal is to size the opening in the pouch to fit closely around the stoma. Now, as you will see in your handout, some of the barriers have a plastic film, and if that plastic film rubs right against the stoma, it can cause stoma damage. So if the products that you use in your hospital, if the barrier has a plastic film, you want to teach patients and staff to size the opening in the wafer slightly larger than the stoma, about 1/16 inch clearance, just a tiny little rim of skin. If they have an ileostomy, obviously you have to protect that little rim of skin, but that's easy to do. You just put a little ring of paste around the back of the pouch, put it down, that little bit of exposed skin is protected. If you have a very soft barrier, and I brought one if I can find it, which I might not be able to. Okay, so some of the barriers on the market are very, very soft. And if they're very soft, if you have a soft moldable barrier, you can literally size the barrier to fit right around the stoma. So it goes back to knowing your products, talking to your vendor reps to ask them the characteristics. Is there a plastic film on this barrier? Should I size it slightly larger than the stoma? Or is this barrier very soft and it's safe for me to literally size it so that it hugs the stoma? So protruding stoma, either right up against the stoma or just a little tiny bit of clearance. But if your stoma is skin level or retracted, you need more clearance in general. When you have a stoma that's skin level or retracted, you basically have two choices when it comes to pouching. We will talk in more detail in the next class about those choices and how you decide which of these is best for this patient. So I'm just going to talk in general right now. But one option is to use a convex pouch. And you can see that a convex pouch has a convex contour so that it's going to push in right around the stoma, and it's going to support the skin right around the stoma, support the skin and the tissue, provide a lot of support so that it kind of forces the drainage to go into the pouch instead of running underneath. Makes it much less likely that you'll get undermining because you've got a lot of firmness and support right around the stoma, pushes in around the stoma, and helps the fluid project into the pouch. If you're using a convex pouch, your whole goal is to support the skin and the underlying tissue immediately adjacent to the stoma. So you want it sized to fit closely around the stoma, usually about 1/16 inch clearance. So if you have a 1 inch stoma, you would have a 1 1/8 inch opening. That 1 1/8 inch opening would essentially give you 1/16 of an inch clearance all the way around. That's just enough clearance to prevent trauma to the stoma, to minimize undermining, but to assure that you get support where you need it, right around the stoma. You're trying to push it around the stoma so the drainage projects into the pouch. However, in some situations you're unable to use a convex system because maybe you have a stoma that's retracted or skin level, but it's also located in a deep crease and you can't use convexity. In that case, you would need to size the opening in the pouch to clear the stoma by at least 1/8 to 1/4 of an inch. That's necessary to prevent undermining. When you have a skin level or a retracted stoma and you're forced to use a flat pouch does not give support to the peristomal skin and tissue, does not cause the drainage to project into the pouch. So what you need to do is you need to cut the opening of the pouch a little bit wider so that the drainage is less likely to tunnel under. And then you'll use your barrier products to protect the skin against stool, or you'll use a sealant to protect the skin against urine. So 3 things I want you to take away at this point, and we'll discuss this more when you're on site. If your stoma protrudes, you're looking for your pouch to fit closely around the stoma. If you have a nice soft barrier, it can literally hug the stoma like a turtleneck. If you have a stoma that is skin level or retracted, but the surrounding skin is relatively flat, you're going to reach for a convex pouch to create a lot of support and pressure around the stoma to force the drainage into the pouch. And you want that support to fit closely around the stoma, so you would give minimal clearance, about a 1/16 of an inch all the way around, which translates into cut your opening or order your pouch 1/8 inch larger than your stoma. And this is what you think about. If my stoma is 1 inch and I want 1/16 inch clearance here, 1/16 inch clearance here, it ends up being 1 inch plus 2/16, or 1 1/8. So if you want 1/16 inch clearance, you double that. You add 1/8 of an inch to the stoma size, and you would order a pouch with a 1 1/8 inch opening. So a convex system should fit closely. However, if I'm in a situation and I have a stoma that is skin level or retracted, and it's also in a deep crease or adjacent to a deep crease, and I'm unable to use convexity and I have to use a flat pouch is not going to give you support, so you need to create a larger opening. You need at least 1/8 of an inch on each side of the stoma. You might need a little bit more to assure that you have a nice, secure seal and to minimize the risk of undermining. That will leave exposed skin right around the stoma. If it's a fecal stoma, you'll use a flat layer of paste. If it's a urinary stoma, you'll use the sealant. Those broad principles, and we'll talk more on site. Now, in looking at matching your pouch to your patient, I'm going to go over some general characteristics very quickly, and again, these are things we'll talk more about when you're on site. Some of the things would seem very obvious, but Rose and I have concluded that in clinical practice, nothing is so obvious. So you have to teach your staff. If the patient has a urinary stoma, you need a urinary pouch with a spout. If they have a fecal stoma, they need an open spout that will allow drainage of stool. If they have a fecal stoma, they may long-term be a candidate for a closed-in pouch. So a closed-in pouch can be an appropriate choice for a patient with a left-sided colostomy who has only 1 to 2 stools a day. Closed-in pouches are covered at the rate of 2 a day. There are some patients who hate the idea of emptying the pouch. They're okay with changing it. They just don't want that whole opening up the end and dumping stool out and cleaning and all of that kind of stuff. And if they have a left-sided colostomy, we can put them in a closed-in pouch. So think about a closed-in pouch for people who say, I can change, but I hate emptying. And they're emptying less than twice a day, once or twice a day. Think about a closed-in pouch for someone who has very limited dexterity and has trouble manipulating the spout and draining the pouch, but would be able to peel off and apply. So fecal pouches come in drainable and closed-end. Urinary pouches, of course, come with a spout. I should mention that most of us in ostomy care believe that all patients with a fecal diversion should be taught how to manage a drainable pouch, because every patient with a fecal diversion at some point is going to have an episode of diarrhea, and they are going to need to use a drainable pouch for that period of time. So typically, even if we have a patient with a left-sided colostomy and we think, yes, within the next few weeks we can move you into a closed-in pouch, we will usually start with a drainable pouch, and we'll tell them why. This is not what you're going to be wearing all the time, but we need to teach you how to manage this, because this is what you will need to use during episodes of diarrhea, and you always need to keep some of these on hand. Flat versus flexible versus convex, that's a very important decision. We'll spend a lot more time on this in a later class and when you come on site. Flat pouches are like this. Most of your two-piece systems are flat, not all of them, but most of them are flat. Most of your flat pouches have rigid components, so they have a flange to which the pouch attaches, or they might have a belt ring. If I have any rigid components, that means that this cannot contour to creases, and so your flat pouches in general are considered to be a good choice when you have a relatively flat pouching surface, but not a good choice for creases, and also not a good choice for a stoma that's deeply retracted in a valley. So flat pouches, when are they a good choice? When you have a flat pouching surface. The next option is all flexible. All flexible pouches will literally fold in two. And so if I have a very firm abdomen, I might need an all flexible pouch to contour around that abdomen. If I have deep creases, I probably need this all flexible pouch to fold into the creases. So very firm bellies, firm rounded abdomens. Think of a pregnant abdomen. They usually need all flexible. Deep creases need all flexible. And then the third option is your convex system. And you're going to think about using convexity when you have a stoma that is skin level or has retracted down into a valley. Basically, we're always trying to pick a pouch that matches the abdominal contours. So if the abdominal contours cave in, then we want a convex system to fit that defect. We will talk in more detail about that because that's such an important factor when you're selecting a pouch for a patient. Can I use a flat pouch on this patient? Do I need an all flexible pouch to contour to their abdomen to fit into creases? Or do I have either a skin level stoma or a valley situation and I need convexity? One piece versus two piece. Most of you will end up in settings where you have access both to one piece pouches, which obviously are all put together in one piece. So you have the pouch attached to the barrier, it sticks on, and it's removed in one piece. Now there are advantages to the one-piece system. First of all, they're very, very low profile. So some of your patients who like to wear very tight jeans might prefer one-piece pouches because there will be no ridge from an attachment flange, very, very flat. Also, they're simpler for patients who have limited dexterity and have a hard time putting pieces together. The one piece, they don't have to do that. The one thing that people find limiting about the one-piece pouch is some patients like to be able to snap the pouch off while leaving the barrier ring intact. They like to take the pouch off and either throw it away and replace it, or take the pouch off, wash it out, and reattach it. And of course, with the one piece, you can't do that. Another thing to consider is if you're teaching a patient with a two-piece system, you can put the flange down and they can see easily that they've centered the pouch around the stoma, and you can't see that as clearly with a one piece. So advantages and disadvantages to both. And so what you'll think about in selecting a pouch for your patient, you'll think about their dexterity. You'll talk to them about their clothing choices. You'll talk to them about their priorities. Do they want something that's super flat, super easy, peel off and reapply? Would they rather have a pouch that gives them the option to remove the pouch and replace the pouch? So different priorities for different patients. Pre-cut versus cut to fit, pretty obvious. A lot of your pouches do come, they're already pre-cut. That's great for patients who have relatively round stomas that have already shrunk down. Patients who have very irregular stomas typically need cut to fit. And then there are some optional features. I brought pouches that have at least some of these. A lot of your pouches have belt tabs, which allows the patient to attach a belt for more security. That's appropriate only if the stoma is close to the belt plane or close to the waistline. If the stoma is close to the waistline, then they can attach the belt and it will give them support at 9 o'clock and 3 o'clock. In contrast, if their stoma is in the lower quadrant and they attach a belt, it will tend to pull the pouch up. So some patients benefit from belts. Not all patients are candidates for belts. The second feature is a comfort panel. Most of the pouches now have a fabric panel to keep the plastic off the patient's skin. So it's well named. It's a comfort panel. It makes a huge difference, especially in the summertime. A lot of your fecal pouches have a flatus filter. All of your fecal pouches are completely odor-proof. So the flatus filter has nothing to do with making the pouch odor-proof. The pouch is odor-proof because of the plastic film. The companies that make ostomy pouches actually studied the size of the fecal odor molecule, and then they worked with plastics manufacturers to create a plastic film where the pore sizes are smaller than the odor molecule. So the odor molecule cannot get out of the pouch, and you can be very reassuring to your patients. You can tell them with great confidence, if your pouch is stuck down, the end is closed, the spout is clean, you will have no odor. I can sit right next to you and I won't smell the stool in your pouch any more than you smell the stool in my colon. Because you only have fecal odor when the odor molecule comes in contact with air. If my sphincter is closed, you don't smell my stool. If your pouch is closed, I don't smell your stool. So you want to make that very clear to them. So what's the flatus filter about? You know that gas rises, so when any gas that's produced is going to come up to the top of the pouch, and the flatus filter gradually vents that gas into the atmosphere, but first it forces the gas through a charcoal layer. So the gas is vented, but first it's deodorized. Venting the gas helps keep the pouch flat. Has nothing to do with making the pouch odor-proof, but has everything to do with keeping it flat so it's not creating a bulge in their clothing. And then when you come on site, we'll explain that urinary pouches have something called an anti-reflux valve. The anti-reflux valve just helps keep the skin dry, and I can show you that much better when you're on site. It's not going to show up on the video. Okay, so we talked about matching the pouch to the abdominal contour. So here's 3 slides that show you exactly what we're talking about. The stoma on top, you've got a nice flat surface. You can use a flat pouching system, and you'll be very effective. But if you have a patient with very deep creases, no way you can use a flat pouching surface, or a flat pouch, excuse me. You can't use a flat pouch because you don't have a flat surface. Here's where you have to have an all-flexible system that will bend into that deep crease. When you have a retracted stoma, most of the time we think about convexity, but if you had a retracted stoma in a deep crease, you'd be right back to all flexible. So the last couple of things I wanted to go over before we talk about common types of peristomal skin damage, I wanted to just briefly go over how to empty and how to change. And again, we'll talk more about this when you're on site, but I wanted to just go over the basics. So when you empty is the same across the board, whether you have a urinary pouch or a fecal pouch. You want to empty when the pouch is about 1/3 to 1/2 full, because when it gets past that point, it's going to start pulling away from the skin. I tell patients, when you start feeling the weight of your pouch and you can feel that little tug, you need to go empty your pouch immediately, because if you allow it to continue filling, it's going to be pulling away, you're risking leakage. So 1/3 to 1/2 full. Urinary pouch is very easy. You either pull the spout, and like you do in this case, some of them have a flip top, some of them have a twist. So you open the spout, drain, dry the spout, and close. Very simple. With fecal pouches, it matters whether it's a clip-based system or what we call an integrated closure system. So if you have a clip-based system, what you want to teach patients to do is to hold the pouch up. Let's see if I can do this. So I'm going to come over here. You want to teach them hold the pouch up, take the clip off. Turn the end of the pouch back so that it forms a cuff. Oops, my pouch came off. That's bad. Then I guess I wouldn't have to drain it because it'd be draining all over the place. So turn it back on itself so that it forms a cuff. Then drain the pouch. Then you can take toilet paper or a wet paper towel or wet ones, whatever. Clean the spout very well and flip it back down. So by creating that little cuff, you keep the spout completely clean. And that makes it much nicer to empty because they're not getting stool all over their fingers. That one little technique makes patients feel much cleaner in emptying their pouches and significantly improves their protection against odor, because this end stays completely clean all the time. So that little cuff technique, a very important thing to teach patients and caregivers if you're using clip-based pouches. If in your system you have integrated closures have to be pinched to form a funnel, and then you drain the contents. You have to take either a wet one or toilet paper, clean on the inside, drop that, and then you always fold up toward your nose and close it. And again, the end stays clean. So different techniques for integrated closure and for clip-based, but your goal is no stool on the outside of the pouch, nothing that can cause odor. Now notice I did not talk about rinsing the pouch. Rinsing the pouch is not necessary, and we don't encourage it on a routine basis because it adds time, adds complexity, adds mess. If it's important to a patient to rinse, I will teach them how to rinse, but I will emphasize to them that they need to use cool water, because warm water will compromise the odor-proof feature of the pouch by dilating the pores in the plastic material. So they need to use cool water, and they should not be aggressive, because if they're aggressive and putting water in their pouch, they're going to tend to wash away the protective paste, protective barrier products right around the stoma. So we do not encourage rinsing. What we usually find is that once we switch patients into opaque pouches, they don't feel as much need to rinse. It's when they look down and see stool that they feel the need to rinse. So moving them into opaque pouches, once they're comfortable getting their pouch lined up correctly, that can be very beneficial to them, makes them much more comfortable, and makes them, or eliminates that sensation that they need to rinse for most patients. Also, you should notice that if you teach patients to put toilet paper into the commode before they empty, it reduces noise and splashback. Now, basic pouch change procedure that I want to go over with you, you want to keep it very, very simple. I remember having some patients who had some cognitive impairment, and for those patients, I put them in a one-piece pouch that was pre-cut. And I literally got it down to the point where I said, take off the old pouch, wash your skin, wipe your skin with this clear protective wipe, stick on the new pouch. You want to keep it as simple as possible. So you're going to take off the old pouch, push-pull technique, clean your skin with warm water. You're going to make sure your pouch opening is sized correctly. You're going to make a decision as to whether or not to use a sealant routinely. We talked about the issues there, but if you are going to have them apply sealant, this is the point where they would do it right after they wash and dry their skin. Put on the sealant, let it dry. If you have a fecal diversion with mushy or liquid stool, you're going to teach the patient to apply a ring of paste right around the cut opening and then press their pouch into place. Simple, simple, simple. Okay, we've talked about the critical aspects of protecting peristomal skin. Gentle technique, appropriate use of your sealants and your skin barrier products. Teaching patients to size the opening in their pouch correctly based on whether or not their stoma protrudes or is skin level, and whether or not they're using convexity or a flat system. We've talked about appropriate frequency for pouch change. One thing I forgot to mention, and I apologize, I forgot to talk about the indications for PRN pouch change. And you want to teach patients. You're going to change your pouch at these fixed intervals. But anytime you realize that your barrier is softening and loosening, change your pouch. Anytime you have peristomal itching or burning, change your pouch. Don't wait, because your skin is being damaged. So now we're going to talk about peristomal skin complications. We're going to talk about the most common types of peristomal skin breakdown, causative factors, what we can do to prevent, how we recognize and manage. Now, I can tell you that if a patient calls their physician and starts talking to their physician about a problem with their peristomal skin, he or she is almost always going to refer them to you. Most of the time that's appropriate, because most of the time whatever problem they're having relates to damage from the drainage, damage from one of the products they're using, incorrect technique, whatever. But sometimes they have a peristomal skin condition that is totally unrelated to the stoma. So I'll say this now, I'll say it again at the end. If you're evaluating a patient with a peristomal skin problem, you have no idea what it is, or if you thought you knew what it was and you initiated appropriate treatment and they didn't improve, never hesitate to refer a patient. I have a friend, she had a patient who was referred to her after multiple consults to other providers who thought she had pyoderma. She did not, she had a peristomal malignancy. Fortunately, my colleague recognized that, you know what, this didn't really meet the criteria for pyoderma, insisted on a biopsy, but it was too late because there had been a major delay between onset of this lesion and appropriate diagnosis, and despite chemo, she died. We don't ever want to be in that situation. So if you see something and you don't know what it is, it's very appropriate to say, I'm not sure, I'm going to refer you to dermatology, I want to get a biopsy. Okay, now your management principles go right back to the things you know about wound care. Anytime you have a problem with skin breakdown, your first goal is to figure out what caused this problem so that you can correct the etiologic factors. Then we want to pursue treatment that will promote healing and will provide a pouching surface. And we've already talked about indications for referral. Now, in doing differential assessment for peristomal skin breakdown, you want to look very critically at location and distribution, and you want to look very critically at patient complaints. This is on your handout. I'll go through it here. If the damage to the peristomal skin is concentrated in the area beneath the stoma and to the side of the stoma, it almost always is related to the drainage. It's going to follow the path of the drainage. So if I see that distribution, I'm going to look at the back of the pouch to see, am I getting meltdown on the back of the pouch? If I'm getting meltdown, it suggests the drainage is running undermining my pouch seal, and that my damage is due to contact between the drainage and the skin. If I have an area of erythema and itching and blistering that matches the area in contact with a certain product, like what if it matches the tape border? That's going to be a tape allergy. Matches the pectin barrier ring, pectin allergy. If I have a maculopapular rash with distinct satellite lesions, you know very well that's yeast. If I have patchy superficial skin loss, that's usually mechanical damage from picking, from traumatic removal. If I have a solitary painful ulcer that's just getting bigger, that's usually pyoderma. In terms of symptoms, patients who complain of itching almost always either have a yeast rash or an allergy. If they complain of tenderness, it could be any type of skin loss. So tenderness can go along with mechanical damage, can go along with early damage due to drainage. Burning pain is that irritant dermatitis caused by contact with drainage. If a patient tells you, after I get my new pouch on and my skin's all covered, I feel pretty good, but then within a couple of days, anytime anything comes out of my stoma, I have that burning pain. That burning pain occurs when the drainage contacts that damaged skin. It tells the patient you need to change your pouch immediately. It tells you that this is probably an irritant contact dermatitis. And if it's constant severe pain, it's almost always pyoderma. So we're going to look at each of those quickly. We'll talk more about this when you're on site as well. Mechanical damage is just what it says. You're mechanically abrading the skin. This is what happens when people rip their pouch off. This is what happens when people pick off paste. This is what happens when people scrub their peristomal skin. You can also get mechanical damage when the hair grows into the barrier product, and then there's there's aggressive removal of the hair, because when you take the barrier off, you're pulling the hair out by the follicle. In addition, and this is most common in patients who have a very firm abdominal wall or patients who have a peristomal hernia, if they're also wearing a belt or they have a rigid pouching system, they can get traumatic damage where the rigid component of the pouch is cutting into the abdominal wall or where it's rubbing against the abdominal wall. So occasionally we'll see mechanical trauma from a very tight belt or a binder or a very rigid pouch over a very firm, rounded abdominal surface. Clinically, mechanical damage looks very much like this. So you might have some erythema, and then you have these little patchy areas of skin breakdown. This patient had two things. He was picking off paste. Also, he was not shaving his hair. He was just letting the hair grow into the barrier and then just snatching it off. So he had a folliculitis, and he also was picking. They typically have patchy erythema and skin loss. They do not usually have itching. They might have some tenderness, but no significant pain. So the big issue is figuring out what caused this. going through with them, making sure they understand the importance of gentle removal of the pouch. Push, pull, just like you see on top. Making sure they understand, don't pick off your paste. If you have residual paste, you have two choices. You can add ostomy powder to make it drier and then roll it off with a dry paper towel or a Q-tip. Or you can add water and smooth it with your finger to make it flatter. But don't pick it off because you'll cause skin damage. So don't jerk your pouch off, don't pick your paste off. If you have a patient who has a very hairy abdomen, you want them to routinely use a sealant so that there's a film, a plastic film over the hair that helps to minimize ingrowth of the hair into the barrier. It can also be helpful to use a solvent for pouch removal so that you're dissolving the bond between the barrier and the skin and you're not pulling that barrier away. In terms of managing, we do our crusting with our stoma powder, not our stoma, crusting with our stoma powder and our sealant, just like we talked about. And you can also think about using a thin hydrocolloid around the stoma under the pouch if you have significant areas. Like if I have severe folliculitis where the hair's been ingrowing into the barrier, and I want something that has less aggressive adhesion than the barrier, then I might crust, I might put an extra layer of sealant, and then I might put a thin hydrocolloid pouch on top of that. What's the advantage of the thin hydrocolloid? Separates from the skin more readily, less aggressive adhesion, less trauma to the hair follicles and the underlying skin. This is classic, both of these are classic enzymatic damage, so look at the pattern. And I apologize because this one got rotated, but the damage here, this was actually the inferior aspect and this was medial and that was lateral. Much clearer here. But with both of these, the damage was concentrated at the area where drainage touched the skin. And when we took off the pouch and we looked at the pouch, we saw meltdown of the barrier in the area matching the skin that was damaged. So if you can just mentally rotate the picture on top, then so that it kind of matches the picture on bottom, that's classic presentation. Also notice that this is not patchy. You have generalized erythema and then you typically have significant denudation. It can occasionally extend through the dermis to the sub-Q, but most of the time it extends into the dermis. These patients typically complain of acute tenderness and pain when the drainage contacts the open area. Now, obviously the most important thing is to figure out what caused this so that I can correct the underlying problem. Let me just go back. I can tell you with both of these, what we had to do, this patient had a prolapsed stoma and was not able to even figure out how to size her pouch or get her pouch to fit around that prolapsed stoma. Once we reduced the prolapse, crusted the damaged area, put on an appropriate pouch size to fit around the stoma, her skin cleared up in just a few days. This patient was 8 weeks post-op. What had happened was her stoma had shrunk down in height, and when she had peristaltic activity, the stoma literally pulled in. She emptied at skin level. So what we had to do for her was put her in a convex system. So this patient needed reduction of her prolapse and appropriate fitting of her pouch right around her stoma. This patient needed convexity. So figure out the problem so that you can secure a pouching system that will prevent contact between that enzymatic drainage and the skin. Anytime you have liquid stool, both of those patients had liquid stool, you need to use paste right around the stoma to caulk the junction between the skin and the pouch and to protect any little bit of exposed skin. We talked about the importance of teaching patients to change their pouch not only on schedule, but also immediately PRN for any indicators of leakage. And then in terms of managing the damage itself, again, crusting, use of a thin hydrocolloid, a lot of the things will cross over. Candidiasis, I know you know what yeast looks like. So here you have your rash that's solid in the center, maculopapular rash, solid in the center, distinct satellite lesions. This little girl, 10 days prior to this clinic visit, had gone to her pediatrician, fever, sore throat, diagnosed with strep throat, put on antibiotics. She had a urinary diversion. You can follow it out. The antibiotics, of course, knocked off the bacteria. She got yeast overgrowth, urine carried yeast out into the skin, and she has a severe candidiasis. In terms of treatment, you're going to crust, but you're going to use an antifungal powder to crust. Miconazole is actually better than nystatin. And this is the reason. Miconazole has a broader spectrum of activity against fungal organisms than nystatin. So if you have access to both miconazole and to nystatin, I would go with miconazole. If you only have nystatin, then use that. So maintain a good seal so that you're minimizing contact between the yeast organisms and the skin. You want to keep the skin under the pouch dry. In the summer in the South, a lot of times we have patients coming in, they have yeast all under their pouch because the pouch is against the skin and is trapping moisture. So your pouch cover is very, very helpful in keeping plastic off the skin, keeping the skin dry, keeping the patient much more comfortable. But once they have the yeast rash, it comes down to crusting with the antifungal powder, nystatin or miconazole. Much better approach than trying to use a cream or an ointment, which of course is going to compromise your pouch seal. What about oral antifungal products? What about diflucan? We don't typically use oral agents. We would think about an oral agent if we had a patient who presented with, say, oral thrush and candidiasis in the axillary area, in the groin, in the peristomal area. But if we have a patient who has a yeast rash concentrated in the peristomal area, no other evidence of a yeast infection, we're not going to go systemic unless they fail topical therapy. So you think about systemic antifungals only if you have multiple sites involved or you have a peristomal candidiasis that is totally refractory to topical therapy. What about bacterial infection around the stoma? Well, first of all, you're very unlikely to see this. It is extremely uncommon. However, you could occasionally see a cellulitis around the stoma, or you might see a very severe folliculitis that produced a crop of pustular lesions. Now, in this case, we had a patient, and this turned out to be atypical pyoderma. This turned out to be the pustular form of pyoderma. But on presentation, the patient clearly has some degree of an underlying cellulitis or appeared to have an underlying cellulitis, acute tenderness, induration, some heat. We couldn't tell on initial assessment, was this simply pyoderma? Was it just a cellulitis accompanying severe folliculitis? So the decision was made to treat with antibiotics first because you would never want to put a patient on steroids if they had a cellulitis. So we treated with antibiotics. The cellulitis actually did respond, but then it was clear that we had a pyoderma and we had to follow up with steroids. So I put this in because I don't actually have a slide of a classic bacterial infection because in all these years we haven't seen one. But in the literature, it is occasionally written up that you could have bacterial infection around the stoma. So if you have a patient who presents with what looks like cellulitis, you're going to pull the physician in, you're going to make the decision jointly to treat that patient with systemic antibiotics. If you have a patient who comes in with very severe folliculitis and a crop of pustular lesions, you might also elect to treat with systemic antibiotics, but more commonly they'll treat topically if it just seems to be a severe folliculitis. Usually we do gentle cleansing. We might crust with an antibacterial powder. Primarily we're going to do crusting, and we're going to eliminate trauma to the hair follicles. You might occasionally have a stitch abscess around the stoma. If you have a stitch abscess, they'll drain and treat topically. So if you have a patient who presents with what looks like cellulitis, we almost always are going to treat them like cellulitis because the safest thing is to treat with antibiotics in conjunction again with the physician. If you have an isolated bacterial lesion like a stitch abscess, typically you just remove the stitch, clean and drain the area, treat topically just with a pectin powder. If you have a very severe folliculitis, you're going to cleanse the area. You may use an antibacterial powder with crusting. Your major focus is stop the trauma. Many of you have seen pyoderma gangrenosum. It sounds terrible, and it is terrible. If you break the words down, it tells you a lot about how these lesions present. So pyoderma, pyo means purulent, derma means skin, gangrenosum means necrosis. So what you have is a purulent process involving the skin that causes skin loss. Typically, pyodermal lesions are full-thickness lesions. They end up healing with granulation and epithelial resurfacing, so you do get scarring. So what do we know about pyoderma? We know that it's an autoimmune process that attacks the skin and that causes full-thickness breakdown. We talked about that. We know that patients who have other autoimmune conditions are higher risk, specifically patients with inflammatory bowel disease, patients with rheumatoid arthritis, patients with malignancies, patients on chemotherapy. We know that pyoderma most commonly presents as a solitary cratered ulcer that then progressively enlarges. Sometimes you have multiple craters, and occasionally, as I said, it presents as a crop of pustular lesions, sometimes hard to distinguish from an underlying cellulitis. But look what's involved. Pyoderma is always extremely painful. I talked to you about that patient who had been treated for pyoderma, but my colleague really did not believe this patient had pyoderma. And when I asked her why, she said it's not painful. And I have never, ever had a pyoderma lesion that was not acutely painful. I have never had a patient with pyoderma who did not have intense pain. So the characteristics of pyoderma lesions, typically solitary ulcers unrelated to drainage, unrelated to mechanical trauma, clearly not an allergic reaction, clearly not a yeast rash, a solitary ulcer that just pops up, is acutely painful and progresses steadily. Most of the time in our patient population, our ostomy patients, most of the time peristomal pyoderma occurs in our IBD patients who have ileostomies. Now, as you know from our discussion in the wound module and from your review of the materials in the ostomy module, there's no definitive diagnostic test for pyoderma. We can have the lesions biopsied. Dermatology will do that. They will biopsy the lesions. And the biopsy report will show acute and chronic inflammation. It will not say pyoderma. But what is pyoderma? It's an inflammatory process. So if you get a biopsy report back that says acute and chronic inflammation. That is consistent with a diagnosis of pyoderma. How do we prevent it? We wish we knew. We don't know. Once the patient's had one episode of pyoderma, recurrence is very common. One of the things we do teach them is very, very gentle stoma care, because most pyoderma lesions are associated with pathergy. Pathergy means very minor trauma to the area causes a major exacerbation. So once they've had a pyoderma lesion, we tell them be very gentle in your peristomal skincare. You don't want to start another lesion. If you have another lesion, you don't want to make it worse. Minor trauma can make pyoderma much, much worse. It's an inflammatory process. How do we treat? Systemic and or topical anti-inflammatories. Most commonly, patients are started on high-dose steroids, 60 to 80 milligrams of prednisone a day. They may also be begun on topical agents, either topical steroids or anti-rejection drugs like tacrolimus. They might be begun on a topical anti-inflammatory dressing like hydrophilic blue. Some of you may have used that. Some clinicians use intralesional steroids, so they actually inject triamcinolone into the dermal tissue to try to get the steroid right at the source of the inflammatory process. Bottom line, you have to treat them systemically. It's not enough to treat them just with a topical agent, or at least it's very rarely enough. So most of the time you either have to give them systemic steroids, something like Remicade, that's been very effective, intralesional steroids, whatever. Then topically, you want to use an absorptive dressing, an alginate, a hydrofiber, the copolymer starch dressing, gold dust. All of them have been used very effectively. Then cover with either a thin hydrocolloid or a thin silicone adhesive foam and pouch on top of that. So what it all comes down to, treat the inflammatory process. Treat it systemically or intradermally as well as topically. Then follow your principles of wound care. Use an absorptive dressing that keeps the surface moist and provides a traumatic removal. Create a pouching surface that will not cause trauma with removal, thus your thin hydrocolloid or your thin silicone adhesive foam. Pain management is essential. Some of these patients benefit a lot from lidoderm patches applied adjacent to the stoma. You've got to work with the physician to make sure that these patients are on appropriate pain management. These lesions are incredibly painful. When you go to change the pouch, it may be very helpful to very gently peel off the pouch and the dressing, to take gauze, saturate it with lidocaine or xylocaine gel, put it on top of the area, and wait for 15 to 20 minutes for that to take effect. The last few things we're going to talk about, allergic contact dermatitis. We've said patients can develop an allergy to any product. Most commonly, we see tape allergies. So this is a tape allergy. You can see complete sparing of the area that was underneath the barrier ring. This patient, we first thought that he was reacting to the barrier ring, but it turned out he was reacting to benzoin. The skin prep had not come up, so the staff nurse used spray tincture of benzoin underneath his pouch, and he was reacting to benzoin. So that's your detective work, is to figure out what they're reacting to. If you're not clear, then you're going to end up doing patch testing to figure out exactly what they reacted to. So clinical presentation we've already talked about is going to match the area that's in contact with the allergen. Now, I wanted to point this out. Sometimes you'll have one area that's more intensely involved than another. And this patient, this was the inferior aspect of the stoma. The patient was reacting to tape, but the top part was not as severely involved, and that's because the bottom part was under the patient's underwear. The top part was not. So on the inferior portion of the pouching surface, there was heat and moisture that exacerbated the allergic reaction. So the part of the pouching system that was under the patient's underwear, it was summertime, so the patient was also sweating. So the heat and the moisture actually created dilatation of the pores in the skin, which facilitated transport of the antigens and exacerbated the allergic response. So that's why sometimes it'll be more acute in some areas than the other. The characteristics, you'll have erythema, you might have small blisters, and most of the time the patient describes it as being itchy and tender. Not surprisingly, the critical aspect of management is to figure out what's the allergen and remove it. So if they're reacting to tape, I have a patient right now who's reacting to tape. Until we could get her order for tapeless pouching systems in, we immediately ordered that, but until those came in, we taught her to cut the tape away so that there was no tape on her skin, and to wear a snug undergarment so that she had good support for the barrier portion of her pouching system. That's what she needed. That took care of it until her new pouches came in. So eliminate the allergen. Now, what if they're having a lot of itching and burning? You can use a small amount of steroid cream. You can use Kenalog spray. You can use over-the-counter Benadryl gel. It's either an antihistamine or a low to mid-potency steroid cream. Small amounts massaged in thoroughly, allowed to dry before you put the pouch on. And then if it's hard to figure out exactly what the patient's allergic to, if you're set up to do patch testing, that's fine. You have the guidelines in your course materials. But many times we'll end up working with a dermatologist and we'll say, look, I know the patient is reacting to this or this or this or this. Here are the commonly used tapes. Here are the sealants, et cetera, et cetera. And they'll help us with patch testing. Cabot medusa, peristomal varices. This was a child who had biliary atresia, portal hypertension, so significant scarring in the liver. It created a lot of back pressure to the veins that were trying to deliver blood from the GI tract to the liver. As a result, the child developed varices, varicosities all the way around the stomach. Here's the issue. First of all, the fact that the patient has advanced liver damage tells you that they're higher risk for a GI bleed. So we have to watch them very carefully. We have to tell them, if you start having blood draining into your pouch, go straight to the emergency room. They're also at risk for surface bleeds from the stoma, and if you are aggressive in pouch removal or cleansing, in the literature there are reports of people unroofing the varices with blood shooting to the ceiling. You don't want that to happen, clearly. So what we teach them is you have to be really, really gentle in providing peristomal skincare. We always use a sealant because we don't want aggressive adhesion. We always use a solvent to remove the pouch. So you use a sealant between the skin and the pouch. You use a solvent to remove the pouch. You use very gentle cleansing technique. Okay. If they are oozing from the stoma itself, they can use pressure. You can use silver nitrate. If they're having a frank bleed, they go to the emergency room. And then the last thing I wanted to mention is maceration. This is also associated with pseudoverrucous lesions. So you can have skin that is simply overhydrated and macerated, but if skin is chronically exposed to moisture, you'll develop these wart-like lesions, and that's why they're called pseudoverrucous. So if you look at the top, this is a patient with a urinary diversion. And The skin was being exposed to constant contact with urine, as was the stomach. And so the patient developed these soft, flat, wart-like lesions around the stomach. That was the skin's response to constant contact with urine. On the bottom, this is a patient with an ileostomy, and this patient has a combination problem. He has both the pseudoverrucous lesions, and you can see kind of the little wart-like lesions where he's had prolonged exposure to liquid stool, but then he also has that irritant contact dermatitis causing skin loss. So he's got those wart-like lesions and skin loss all going on at the same time. And we've actually seen this in a number of our ileostomy patients who had high volume liquid output and who had skin level stomas where it's very hard to maintain an effective pouch seal. So the underlying problem is prolonged contact between the skin and moisture. In order to correct this, we have to correct the pouching problem. Now, this patient had acute tenderness from all of these pseudoverrucous lesions. So what we ended up doing was we treated the pseudoverrucous lesions with Kenalog spray to actually flatten out those lesions to reduce the inflammation. That allowed us to apply a convex system, which the patient needed to keep the stool off of his skin. Initially, when we tried to apply a convex system, he had so much tenderness from the pseudoverrucous lesions, he had a really hard time tolerating it. So we ended up using the Kenalog spray to flatten out the pseudoverrucous lesions, using very flat paste to protect the peristomal skin, using very low-level convexity until we got the pseudoverrucous lesions under control. And once we got them under control, we were able to go with deeper convexity to stop the problem. With this patient, we were able to just use a sealant to waterproof the skin because it was just urine, so we were able to use a sealant and convexity. So you've got to do these two things. You've got to correct the pouching problem to stop the contact between the moisture and the skin. And then you've got to use either a sealant if it's urine alone or crusting if you're dealing with liquid stool to actually treat the damaged skin. So always we're focused on trying to prevent skin damage. That's why we spend so much time on how to protect the peristomal skin. But we're also monitoring all the time for complications. If a complication occurs, we step back to determine what's the causative factor, how do I address the causative factor. An across-the-board technique is your crusting technique to treat damaged skin. But your most critical factor is figure out what caused the damage, correct that. If you don't know, refer to dermatology. Okay? That's it. Thank you very much.